Welcome to the Explainer. You know, finding your newborn's arm completely limp right after birth is, without a doubt, a terrifying experience for any parent. Today, we're going to be unpacking the medical mechanics and the legal realities of newborn nerve injuries. We really want to understand exactly what happens in that delivery room, why it happens, and most importantly, what families can actually do about it. So we're going to objectively untangle this highly complex intersection of sudden obstetric emergencies and strict standards of medical care.
I want you to just imagine standing in the quiet of a maternity ward, fresh out of a chaotic delivery room scene, and you're desperately searching for answers to this one terrifying question: why is my baby's arm not moving? Now, parents are often met with these quick assurances from medical staff, right? They're told it's just a temporary weakness. But there's frequently this massive gap between what parents actually observed in that room, the urgent physical maneuvers, the panic, extra staff rushing in, and the clean clinical explanations they get afterward. Today, we're investigating that exact gap.
All right, so here's our clear roadmap for today. 1. The silent newborn arm. 2. The anatomy of the injury. 3. The medical standard of care. 4. Common delivery room excuses. And finally, number 5, protecting your child's future.
Let's dive right in with Section 1, the silent newborn arm. So the unmistakable signs of a brachial plexus injury, which is often called Erb's palsy, are actually highly specific. The most iconic one you'll see is what they call the waiter's tip posture. This is where the baby's arm is turned inward, the elbow is locked totally straight, and the wrist is flexed backward. It literally looks like a waiter discreetly holding their hand back for a tip. Beyond that, parents will notice asymmetrical movement. Maybe the fingers twitch a bit, but the baby just cannot lift the arm at all. Then there's the absence of the Moro reflex. This means if the baby gets startled, only one arm flies up while the other just remains completely frozen. And finally, acute pain and sensitivity. The baby might whimper or cry out just from having that affected arm gently washed or dressed.
Okay, moving on to Section 2, the anatomy of the injury.
The main trigger for these injuries is a specific obstetric emergency known as shoulder dystocia. This is a chaotic, incredibly time-critical event where the baby's head is delivered, but then their leading shoulder becomes firmly wedged right behind the mother's pubic bone. And it's super dangerous, mostly because the umbilical cord can become compressed in the birth canal, which quickly cuts off oxygen to the baby. Now, medical authorities across the board agree that this event is largely unpredictable. It usually just happens without any prior warning signs whatsoever.
But here's the crucial detail. The injury itself isn't necessarily caused just by the shoulder getting stuck. It's often caused by how that stuck shoulder is handled by the staff. And this brings us to the brachial plexus. Think of this as a super delicate network of nerves that starts in the spinal cord and the neck and runs all the way down to control the arm, forearm, and hand. If a doctor panics and pulls too hard on the baby's head to free that wedged shoulder, that physical pulling trauma is directly transmitted to this network. It literally stretches or even tears these vital nerve lines.
Now, not all nerve injuries are identical, right? They essentially fall into 4 escalating categories of severity. We start at the top with neuropraxia. This is the mildest form, where the nerves are stretched but not actually torn, and honestly, it often resolves on its own within about 3 months. Next down is neuroma, where the nerve is stretched and partially torn, causing scar tissue to form that blocks nerve signals. Moving into the really severe territory, we have a rupture. This is where the nerve is completely torn apart but remains attached to the spine. This one will not heal alone, it absolutely requires surgery. And finally, the most devastating outcome is an avulsion. This is where the nerve root is violently torn completely away from the spinal cord itself, requiring incredibly complex nerve transfer surgeries just to restore even partial function.
That brings us to Section 3, the medical standard of care.
So when this emergency strikes, there's a stark contrast in how doctors must respond. On one hand, you have improper technique, excessive downward lateral traction, which basically just means pulling aggressively on the baby's head or neck in a panic, is strictly forbidden. On the other hand, you have the proper protocol. This is a highly standardized, step-by-step sequence of gentle, calculated physical maneuvers. Obstetricians are extensively trained to use these specific maneuvers to safely change the geometry of the mother's pelvis or rotate the baby, entirely removing the need to pull on the head.
Let's actually walk through these 4 specific, safe medical maneuvers. Step 1 is the McRoberts maneuver. This involves flexing the mother's thighs tightly toward her abdomen to literally widen the pelvic outlet. Step 2 is suprapubic pressure, where a nurse applies direct downward pressure just above the pubic bone to try and slip the baby's shoulder right under it.
Step 3 involves internal rotational maneuvers, acting almost like a screw to gently rotate the baby's shoulders. And finally, step 4 is carefully sweeping the baby's free posterior arm across the chest to instantly reduce the overall shoulder width. These steps effectively resolve the emergency. Skipping them and just resorting to pulling is considered a major breach of the standard of care.
Section 4. Common delivery room excuses.
Let's look at the first common hospital defense. You'll hear this quoted straight from defense playbooks. The injury was caused by natural maternal forces. Essentially, they're arguing that the mother's own uterine contractions, pushing the baby down the birth canal, caused the nerves to stretch, completely independent of the physician's hands.
But does that argument actually hold up? Well, it actually carries genuine medical weight, but only under very specific circumstances. If the baby is in a posterior position, natural contractions genuinely can stretch nerves against the sacrum without the doctor doing anything wrong. However, and this is a big however, it becomes a remarkably weak excuse if the baby is in an anterior position, meaning they are stuck behind the pubic bone. In that specific presentation, medical consensus totally shifts. Permanent nerve ruptures and avulsions in this position are far, far more likely to be linked to external pulling by a doctor, not just natural contractions. So the baby's exact position dictates everything here.
The second common defense revolves around unpredictability. Hospitals will very often state it was a sudden, unpredictable emergency. They really want to emphasize that because shoulder dystocia couldn't be foreseen. The chaotic outcome is just an unfortunate, unavoidable tragedy.
But here is the absolutely crucial takeaway. While the emergency itself is unpredictable, that unpredictability does not excuse poor management. Physicians are specifically and extensively trained for this exact scenario. Panic, speed, and the pressure of the moment do not justify abandoning the safe, step-by-step maneuvers we just talked about in favor of yanking the infant's head. The breach of care isn't about causing the emergency in the first place. It's entirely about how the doctor responded to it once it happened. Then we have a third common statement, and this one often comes a bit later from well-meaning pediatricians. They'll say, most babies recover completely, so let's just wait and see. They might even encourage parents to just give it a year or so before taking any major medical or legal action. Actually, scratch that. This wait-and-see approach can be incredibly dangerous for severe cases. Delaying specialized evaluations based on vague assurances can cause your child to completely miss a vital 3 to 6 month golden window. If a nerve is ruptured or avulsed, waiting a year means missing the brief biological time frame where complex nerve transfer surgeries can actually work. You're potentially leaving a child with irreversible physical deformities. And that perfectly transitions us to our last topic, Section 5, Protecting Your Child's Future. First off, it's absolutely vital to understand what exactly constitutes medical malpractice in an Erb's palsy case. Legally speaking, there are 3 core elements that must be proven. First, a breach of the standard of care. This means proving the doctor actively bypassed established protocols like skipping those maneuvers or actively pulling the head. Second, causation. You have to legally and medically link those specific physical actions directly to the torn nerves. And third, damages. This means extensively documenting the lifelong physical, emotional, and financial toll this injury is going to take on the child's life. There are also strict biological and legal timelines that give this issue immense urgency. And I want to specifically highlight some data from Indiana here as an example. Biologically, 3 to 4 months is the benchmark to check for natural recovery. 3 to 6 months is that crucial surgical golden window we talked about. Now, legally, the standard medical malpractice statute of limitations in Indiana is 2 years. However, for birth injuries where a child is injured under age 6, Indiana actually offers a unique extended deadline up to their 8th birthday. Plus, you have to remember that families must navigate an 8 to 12-month medical review panel process before ever setting foot in a court. So the clock is always ticking. So what is the actual practical roadmap for parents facing this? Step 1 must always be securing immediate, specialized medical intervention, ideally from a pediatric neurosurgeon, to truly assess those nerves. Step 2 is crucial. Obtain your complete unedited delivery records, nursing notes, and fetal monitor strips. Seriously, these documents hold the objective truth of the timeline in that delivery room. Step 3 is seeking an independent legal investigation by an attorney experienced in birth trauma. They can help decipher those complex records and really help you understand your options.
As we wrap up, I want to leave you with a rather provocative question that I think perfectly summarizes the tension we've explored today. While shoulder dystocia is biologically unpredictable, is a lifetime of permanent nerve injury the unavoidable result of the emergency itself, or is it the direct result of the split-second human actions taken in the delivery room? Because ultimately, understanding the difference between an unavoidable medical crisis and a breach of a strict duty of care, well, that's the key to finding the truth.
Thank you so much for joining me for this explainer. Keep learning, keep questioning, and I'll see you next time.